the questions that I'm curious about is, as you build out this workflow for providers, or especially ICU care providers, you give them a lot of flexibility in controlling how they should treat or what they should do with the patients, and they can input. You just showed us the example of medications that they need. What are the next steps that the care provider should be doing? How far in depth are you going with this? Are you going to be recommending in the future
No.
next step actions, or is this something
No.
that you will always just prevent data?
So in order to not coming to a very high regulated area like class 3, we decided to stop by providing you the analyzed data, and we're not in any position to come and deal with any treatments. However, what we have done, we have built a system which is helping us to build any protocol that you want to provide. Let me give you some example. One of the models predict that the patient is gonna will need in X, Y, or Z within the next 4 hours. And if you will not intervene, the patient is going to be deteriorating up to the point that he is probably going to be dying or anything like that. In every institution that we're coming, we're providing this kind of information, and we're asking you to put your own protocol. Once I raise the flag that the patient is required 1, 2, 3, 4, what do you want to do? And his coming, and this is his protocol. We're providing a lot of information so he can take a decision, but it's up to him to decide what the physician need to do, what the nurse need to do, and what is the protocol. We're translated in a way that is going to be showed as we're seeing here, but it's up to him. We don't want to take any liability as far as which medication, which treatment, and which type of intervention that you will require. So everything is running, behind the scene. The model is tweaking and providing information, but it's up to you to define exactly what do you want to do from every condition. And we have, a very clear set of items, including best practices that you can come and say, okay, if cases like that happen, I want to see 1, 2, 3, 4, 5. If case B is happening, I want to see something different. And we're just providing you the data both from the control tower side as well as from the bedside. So we're closing the loop for you, but it's not our protocol. Obviously, we can compare notes. Obviously, we can do a lot of, based on the same kind of condition, what institution A has done versus institution B or C, and we can provide an insight with regards to which kind of protocol was better. But we're not in any way, shape, and form recommend anything around that.
Makes sense. And I think that, as you mentioned, it's a lot more complicated when you try to push recommendations to providers themselves.
Yeah, and you know what? It's even more than that. Everyone or every healthcare provider that knows, every institution that we have deal with have their own experience, their own treatment, different kind of medication, different kind of practices. There is no way that we can influence in a way that everything that you have done over the last 10 years is going to basically can change. And bear in mind that by the end of the day, technology here, the technology piece is coming to help us to better treat the patient. But, and this is the big but, everything is around the workflow. If you have a team that know how to practice, there is no way that technology can help you to change everything. You need to build a system around, the workflow that how it's working for you. You need to improve. will provide you more tools, will provide you more insight, but it's need to be easy. It's need to be something that everyone can understand. And this is why we have worked something like over 3 years only in the UI side to provide something which is so easy to implement, so easy to train, so easy to operate it, because we know how the typical EMR is working. Every single hospital that we're going is coming and tell us this is a nightmare. I mean, we're spending more time in front of the computer rather than, with the patients. And what we have done here is we created a system that is 3 screens. That's it. Very easy. You saw how I'm dealing with it. I can drag any kind of formula, any kind of algorithm, any kind of models. I can tweak and I can ask the system to do any kind of comparison and provide me the best insight. Easy to use workflow and make sure that everyone understands the message.